I would like now to introduce Dr. Gail Deutsch. She is our next speaker, and she began her science career in Chicago at University of Illinois, and then worked at the CDC for a year, I think, before she entered medicine at the University of Chicago. She interned at the McGee Women's Hospital in Pittsburgh and began her pathology career as a resident at the University of Pittsburgh Medical Center, and then spent 2 years in her subspecialty fellowship there in pediatric pathology. She then joined the faculty at the Children's Hospital of Denver and at the University of Colorado. And she, in 2008, was recruited to Seattle, where she now serves as professor of pathology. Dr. Deutsch has been incredibly instrumental in describing the phenotype and histopathology of these various and rare entities that our patients portray. She's contributed to early classification scheme to describe diffuse lung disease in children. And so she's here to tell us more about her thoughts on that. Thanks.
Thank you very much. This is a real pleasure, and we're going to switch back to more of a clinical-based talk, though it's also what I would like to emphasize. Hopefully it will give, even these clinical-based studies give real insight into pathogenesis potentially and the origin of disease. So we've heard a lot of exciting work going on about genetic discovery in these rare disorders in general, as well as other modalities like imaging and potential biomarkers that are going to be important in diagnosing lung disease. But we need to step back a little bit and remember that pathology and lung biopsy is really kind of been the foundation for the field and has been traditionally the gold standard of making these diagnoses, and actually, I believe, propelling the field forward. So, but in our current state in 2019, it becomes, when do you actually need to do a lung biopsy? When do you weigh the risk to the patient, the potential morbidity of an invasive procedure to get out a question that you're trying to answer? And it really comes down to being a group decision, a decision between the clinician, between the family, and also, of course, with their radiology and pathology to understand what are the limits of what can be obtained from a lung biopsy and how is this going to drive your clinical care and potential treatment. So there's lots of opportunities where a lung biopsy can be extremely helpful, but also has limitations. Certainly for neonatologists in the group know that neonatal lung disease, determining whether it's lethal versus non-lethal, whether the patient on ECMO, whether discontinued support, lung biopsy often plays a role before genetic testing can be completed. Entities like idiopathic fibrotic or inflammatory lung disease, trying to figure out the origin of what this idiopathic disease is. We can get a sense on lung biopsy whether we're dealing with hypersensitivity, perhaps surfactant dysfunction, or a connective tissue disorder. Bronchiolitis obliterans, often that's still lung biopsy is to confirm that diagnosis and help guide potential transplant options. And then closely related to all this is therapy. Are we dealing with infection? Are we dealing with neoplasia? Are we dealing with inflammatory? This is more apropos to the older children that we see who wind up getting lung biopsies, but it's always a constant problem. And then even things like pulmonary hemorrhage. I mean, certainly for those of you who have dealt with children with pulmonary hemorrhage, it's often unclear whether it's immune-mediated or not, and lung biopsies is still considered the gold standard to determine that. But I want to emphasize as I go through some examples or other examples of how pathology has kind of driven the field forward, that it has several other functions. I think it can still help guide genetic testing, maybe not to the actual gene all the time, but it certainly can lead one to different directions. And I think it still is playing a role into providing insight into pathogenesis. Many of these disorders we still don't understand at all. We just heard about knee high. I'm going to tell you something about a disorder called pulmonary interstitial glycogenosis, another idiopathic disorder, and then even ones where the phenotype is variable, like the surfactant dysfunction disorders. Why is the phenotype variable? What can we predict or not predict, and how are we going to guide therapy in these changes? Lung biopsy still can play a role. And then lastly, and this has been very important in oncology and will probably be important in rheumatologic disorder, is to have material available for patient-based therapies that might come about. That certainly plays a role currently in oncology. So it's always important to know where you came from, and many of you are younger than I am in the group, which I'm continually reminded of when people talk about what year they were born. So I want to revisit the past a little bit and talk about the role pathology has played in defining pediatric ILD, which, to underscore, is rare, a composite of rare disorders, because I think it's really helped move the field forward and gotten to a part where we've made tremendous discoveries. So what is it? We talk about definitions. It's kind of a heterogeneous group of very rare disorders, but what's important about them is that they have a common clinical presentation. There's hypoxemia, tachypnea, dyspnea, there's diffuse imaging abnormalities, and more common etiologies have been excluded. What's important about them and why it's been such a emphasis or a focus, despite the fact that these are rare disorders, is that they have a high morbidity and mortality. Certainly, depending on their pathogenesis, very high. And so diagnostic accuracy is quite critical. So here's an example to underscore this. Again, you have a case in the NICU, a near-term newborn who presents with tachypnea, hypoxemia, progressive pulmonary hypertension in the first few hours of life. You get a lung biopsy. In one example, you're going to see the characteristic histologic changes of alveolar capillary dysplasia with vein misalignment, and I'll talk a little bit more about that later. This is a lethal, or almost invariably lethal, disorder associated, now known to be associated with FOXF1 mutations. But this same presentation, exactly identical, this child might also have something called pulmonary interstitial glycogenosis, which is this diffuse interstitial expansion of these immature mesenchymal cells. But in fact, in this setting, where it seems to be associated with meconium aspiration, the child has a very good prognosis. And especially with supportive care and potentially treatment with steroids, the outcome is quite good. So again, knowing what you're dealing with is extremely important. So now, of course, we have guidelines on how to deal with these rare, what we call child or interstitial lung disease in infancy. But what was it really like before all this? Well, back pre-2005, it was quite challenging to make these diagnoses. And one of the biggest problems was the overlapping terminology that existed. So you'll see some of the examples of the infant disorders as we talk about the diagnoses that children were carrying. Something called chronic pneumonitis of infancy sounded very similar to infantile cellular interstitial pneumonitis or chronic bronchiolitis of infancy. But the difference is, depending on what you said, one we now know is associated with surfactant dysfunction mutations, and one is now also termed knee high or pulmonary interstitial glycogenosis. So again, having that unified terminology was extremely critical to moving the field forward. So 2005, it was a historical time, not only because Amazon Prime came about and YouTube was invented, But it was the time when the Child Network, the participants of the Child Network got together. Not all of them are pictured here, but it was a aggregate of very prestigious pathologists, pulmonologists, neonatologists, and radiologists, and they got together to kind of get a handle on these infant disorders. And it was really under the very persuasive ability of Robin Dieterding, maybe some of you know her, to get Claire Langston. Again, she's been like the mother of pediatric pulmonary pathology. She's defined many of these disorders over the preceding decades. It was her charge to get together all these pathologists and provide consensus terminology and diagnostic criteria for these very rare disorders. And that's how we got together. And the goal is to get that consensus, what became the classification, down, and then we could go on to figure out how prevalent were these disorders, what were their associated clinical features, and what were their outcomes. So just to make a long story and many, many, many hours of work quite short, we got together 11 to 12 different institutions, all the lung biopsies that were performed there during a 5-year period, and all the pathologists got together and reviewed all the cases that were de-identified. And then all these cases were given a primary classification based on their kind of main feature or primary disease process. And to do this classification, we utilized a classification scheme that was put forth by Claire Langston and Megan Bishop in 2004. And the real power of this classification, it has issues certainly with some of the terminology that's used, often descriptive. But the real power of it is kind of classifying very diverse number of disorders under kind of headings that have similar prognostic or clinical implications. So there's something called diffuse developmental disorders I'll talk about, disorders of lung growth or alveolarization, neuroendocrine cell hyperplasia of infancy, and pulmonary interstitial glycogenosis. Got a very cute title of specific conditions of unknown, poorly understood etiology, but we're working on that. And then, of course, the surfactant dysfunction disorders. And looking at the genetic disorders of surfactant dysfunction, as Larry told you about this morning, you can see the power of having that category versus all this terminology on the pathology side has been very important. It's been important in having that kind of genotype-phenotype correlation, even when it might not correlate. But it's certainly given us an idea about what surfactant mutations look like in infancy, enough to tell the clinician, hey, I'm worried about this. And it's also given us an idea what might happen to these lung disorders with time as the patient ages. Certainly it appears with age, potentially with environmental exposure, like this teenager who smoked, that these surfactant mutations can progress to fibrotic lung disease, potentially lethal. So having that understanding is critical. So what about the other disorders? Well, where are we in 2019? I'd say we've made tremendous discovery, and I want to tell you a little bit about that by going through the rest of these disorders, and as also to highlight when lung biopsy can tell you something useful and when it potentially can have, you might want to go a different route. So diffuse developmental disorders, there's been tremendous genetic discovery in this field. They don't have a great name, but what they are, they're rare disorders basically characterized by abnormal lung development, what is considered a primary abnormality of lung development, and they often have vascular changes. They include alveolar capillary dysplasia with misalignment of pulmonary veins, now associated, like I said, with FOXF1 mutations, Cenar dysplasia, and congenital alveolar dysplasia, both very rare disorders, now associated with TBX4 and FGF10 mutations. And all this is very rapidly progressing, these findings. So despite all this genetic discovery, discovery, the reality is that many of these patients are still diagnosed on pathology because they are so sick when they're born, and often genetic testing is not back in time for a diagnosis to be made. So prior to being put on ECMO, or the patients expire and there's an autopsy, the pathologist plays a role in making this diagnosis. And so alveolar capillary dysplasia has very characteristic features. It has what we are terming misalignment of pulmonary veins. I would quiz one of you in the audience if I had time, but I don't. So pulmonary veins are normally in the interlobular septae, not next to the artery in the bronchovascular bundle. So they are misaligned, and the arteries show marked hypertensive changes. So part of the child network, the pathology group, defined criteria to make this diagnosis, which is important because before people didn't necessarily include malpositioned pulmonary veins to make this diagnosis. So you could see that enrichment for having a category that led to the FOXF1 discovery might have been inhibited if we didn't make that kind of clear defined criteria. These can be a challenging diagnosis to make. I have seen cases, and there are reported cases, where the misaligned veins are patchy, not present in certain areas, but present in other areas. And that has been often associated with clinically more benign, well, benign is relative, more later presentation, as it were, and long-term survival. And it's not necessarily always clear why that is. There has been presentation of familial FOXF1 mutation in which the phenotype was quite variable, in which included non-symptomatic members of the family. So it might be due to mosaicism, it might be due to imprinting, but a lot still remains unclear. So again, we don't really have a great understanding of what happens in development that leads to this misaligned veins. In fact, the mouse model does not show this. But Csaba Golumbos and Steve Edmond in the audience did some really elegant work where they did serial sectioning and three-dimensional reconstruction, both in cases of alveolar capillary dysplasia compared to normal controls. And what they found is that these misaligned veins are actually abnormal shunts likely between the pulmonary circulation and the systemic circulation. Whether these are normal shunts or abnormal proliferation of abnormal shunts, I think it still might be unclear, but really illustrative. So Cenar dysplasia and congenital alveolar dysplasia have almost an identical presentation to alveolar capillary dysplasia. They're also considered lethal disorders. And they're fascinating because histologically, as they've been defined decades ago, they seem to represent a halt in lung development. So there's Cenar dysplasia in case reports is often familial. Has occurred in siblings. It seems to be there's an arrest in lung branching morphogenesis at the pseudoglandular stage of development. And then congenital alveolar dysplasia seems to be an arrest slightly later on in the canalicular or saccular stage. This diagnosis in particular, there's very few case reports out there because it's extremely challenging diagnosis to make. You can't make it in a premature infant, obviously, because their lungs are already immature. And if the infant has lived at all, they often have remodeling, and these kind of changes may be really not specific to that disorder. So what has been really fascinating, what's been challenging for pathology, making these diagnoses besides congenital Cenar dysplasia in a preterm infant, is how it's unclear when do you call Cenar dysplasia, when do you call CAD, at what point is arrested development one versus another, and does that have prognostic differences because one seems to be familial Cenar dysplasia and one not so sure. Well, I was lucky to be part of a group that went on to define the genetics of these rare disorders. And what was found is that indeed there is a histopathologic continuum, This is a group of patients with Cenar dysplasia, congenital alveolar dysplasia, and lethal pulmonary hypoplasias that were genetically interrogated by both the Baylor group and the group in France. And this is what was found was enrichment for TBX4 and FGF10 mutations, both coding and non-coding variants. And so the pathology for me was very enlightening because it really was a continuum. And certainly now in idiopathic hypoplasia, I would recommend genetic testing in these instances. So what about lung growth abnormalities? We've talked about bronchopulmonary dysplasia. And certainly they're notorious for having what we call alveolar simplification or new BPD. The reality is, as we looked at a lot of these cases in the child review and looked at what was defined as otherwise idiopathic lung disease, is that a lot of children or infants present with deficient lung growth, not necessarily related to prematurity or oligo, but also maybe due to congenital heart disease or due to trisomy 21, or even just a difficult postnatal course, like in this case of recurrent pulmonary hemorrhage. So it's important to remember alveolar growth does not end with birth. It continues years, well after birth, the majority in the first 2 years. And where you see deficient lung growth of postnatal onset is going to be in the subpleural area, and it often presents with these very prominent cystic changes. So of course, people always ask me, how do you quantify this? And it's not easy. A lot of it is based on familiarity with these with what normal lung looks like, really. I mean, on a lung biopsy, you're hampered by the fact that you can't do lung volume to weight ratios. You can't do lung body weight ratios. You could potentially do radialveolar count, but often biopsies are not large enough to do that, because you need a lot of different measurements. So the reality is you have to look at alveolar size and complexity, which is very dependent on lung inflation and also familiarity with what normal age control lung looks like. So having a lot of lung, when you're talking about getting a lung biopsy, when you don't know what the origin is of this neonatal lung disease or childhood lung disease, it's important to have a large enough biopsy for the pathologist to evaluate. Do not just focus on this peripheral component, because that's where lung growth abnormalities will be accentuated and you might be misled. And then inflation is tremendously important. How you deal with the lung biopsy, it can make a huge difference. Here's an uninflated lung that was put through where it looks like very complex alveoli, no problem. But then the same separate part of this biopsy was formalin inflated, what we call shake inflated, and it shows that there is alveolar simplification. And when I say alveolar simplification, I mean that there's less complexity than normal, and the alveolar spaces are bigger than the bronchial, which they shouldn't be. So it's also important to recognize, and this we've learned with time, is that other things like genetic mutations can present with lung growth abnormalities, and that includes filament A mutations and NKX2.1. And as Larry emphasizes, that you don't always have phenotype in other organs to be able to hone down on that diagnosis. So I've had to widen my differential when I'm faced with an idiopathic lung disorder. So pulmonary interstitial glycogenosis, to me, it's one of the more fascinating. They're all fascinating, actually. But these patients often present quite sick. It exclusively occurs in neonates. They present, like I said, not unlike alveolar capillary dysplasia with vein misalignment, tachypnea, hypoxemia, pulmonary hypertension. They often need mechanical ventilation and prolonged oxygen. And that being said, they often, if you can support these children, they often do well if you can keep them going. And especially pulse steroids have been really helpful in certain cases. So again, this disorder was defined by the pathology. which is this very interesting interstitial expansion by these what are immature mesenchymal cells, and you can actually see them proliferate in the interstitium. So it's a proliferation of these cells, which even on EM are quite immature. They don't have well-formed organelles. What really gave us insight into this disorder was recognizing how frequent we see this. So it was considered, when it was first described by Coutts and colleagues, it was considered a idiopathic disorder of mesenchymal differentiation unique to this particular disorder. But if you look at serial lung biopsies, you actually see focal mesenchymal proliferation characteristic of pulmonary interstitial glycogenosis in a lot of different disorders, most frequently deficient lung growth, but also things like meconium aspiration and even congenital lung malformations like CPAMs. So for that, meaning other people think this disorder is really a reactive process that is in response to neonatal hypoxia and injury. So I told you prognosis can be good, and here's a good outcome in a case of a 37-week infant who presented with severe pulmonary hypertension, had a lung biopsy at the time of hypoplastic arch and co-arch repair. So you can see tremendous hypertension in this vessel, interstitial expansion. He went on to do quite well after his surgery and with support. He did wind up getting a biopsy at 49 days of age, though, because he had a chylothorax, so they went in and did a biopsy. And what we were shocked to find at the time is that there was largely resolution of the pulmonary interstitial glycogenosis. And by that time, he didn't have clinical hypertension anymore. So that's good, and that got the idea that pulmonary interstitial glycogenosis had a favorable prognosis. But here's another case I recently had of a 32-week, also clinically severe pulmonary hypertension, got biopsied. What was really notable was the pulmonary interstitial glycogenosis and the pulmonary hypertension, but I also found occlusive disease, which obviously is extremely rare in a neonate, and I still don't have an etiology for it. So this patient went on to die. Actually, this is wrong. This is 7 weeks of age. And their pulmonary interstitial glycogenosis had resolved pretty much. You can see there's smooth muscle there, but their outcome was dictated by their concurrent major morbidity, which in this case was veno-occlusive disease. So Lisa Young and I have had a lot of interest in defining what these cells are, and we've done quite a bit of work describing that a subset of them represent lipofibroblasts, and hypothesized that these cells have a similar role in surfactant production and alveolarization that they do in the rodent lung. So you've already heard a lot about knee high, so I'm not going to go further into that. I will tell you that this disorder, however, was defined by the fact of when patients that were this sick when they were biopsied had essentially normal pathology. Claire Langston was able to review several of these cases, and she kept saying she really doesn't see anything. What she sees is a little bit of smooth muscle hyperplasia around the airways, a little macrophage accumulation here. These prominent cells, which you're going to figure out quickly what those are, obviously neuroendocrine cell bodies, but nothing else. And so because these cells look so prominent, she did a series of neuroendocrine markers and came up with these were marked proliferation of neuroendocrine cells in this particular disorder, which has a very characteristic clinical and imaging phenotype. So does lung biopsy still play a role? Not very often, actually, because the clinical and the imaging are so characteristic. But it still does, actually. In cases where the infant might be premature or where the imaging is not that classic, I often still see lung biopsies with exclude neuroendocrine cell hyperplasia of infancy. As we've talked about before, neuroendocrine cells can proliferate in a variety of neonatal conditions. We think we see more so in knee high than other disorders, but certainly in BPD they can be quite prominent. So knowing what the rest of the histology looks like, knowing that having a pathologist who's able to kind of think holistically about the lung and why you're getting a biopsy is extremely important. So I've tried to develop criteria for making this diagnosis, but I think the important message for you as the clinicians is that you need to have a big enough biopsy for us to evaluate whether it meets the criteria. You need at least 8 to 10 airways for evaluation, and we've shown that actually this neuroendocrine cell increase can be quite patchy, so having more than one biopsy site is often advantageous. People ask me all the time, do I have to use Bombacin? And I think Kristen nicely illustrated that the answer is yes. For whatever reason, it's very sensitive, more sensitive than other neuroendocrine cell markers. So it's one that I've only validated Bombacin as well as serotonin in making this diagnosis. So lastly, I want to say that communication, we've realized that lung biopsies are getting less frequent. We realize we have other methods of diagnosing these rare disorders. So if you are contemplating getting a lung biopsy, really good communication between the clinician, radiologist, surgeon, and pathologist is essential to maximize the tissue utilization, and how that biopsy is going to get divvied up and processed is really critical to iron out before it happens. The child pathology group has developed a protocol for handling the tissue. This was developed back in 2006, but it's still applicable. My only difference is I would say I prefer the shaken inflation versus the needle inflation because I think it doesn't introduce artifact into the biopsy, which becomes important when you're looking for things like lymphangiectasia. So, to emphasize why getting more than one biopsy is so critical, I see it time and time again where having more than one biopsy site really makes or breaks the case. Here's an 8-year-old who presented with a several-year history, clinical idiopathic pulmonary hemosiderosis. She had recurrent anemia, hypoxia, pulmonary infiltrates. They got a biopsy, and it showed really the characteristic changes that have been described in IPH with this dense hemosiderosis, this mineralization of the vessels. Didn't see any neutrophils anywhere at all. Actually, in this case, there wasn't more than one biopsy, but I leveled the block thinking I got to find it because the clinicians are desperate for a diagnosis. This is really going to guide their treatment. And I found a localized focus of beautiful capillaritis that kind of validated their decision to try more aggressive treatment. So having that kind of knowledge base and knowing, the pathologist knowing exactly what you're looking for is really quite critical. So what's the impact of diminishing lung biopsies? I think it's really going to hamper our ability to characterize the phenotypic spectrum of these very rare disorders. We've done quite a lot, but I think there's still more to do. And I think even with genetic discovery, as Larry said and other people have said, we introduce more complexity and there's more questions than answers. So continuing to correlate with the biopsy is going to be important. Also, as I mentioned before, having the material available for patient-specific therapeutics I think is going to be very important, especially as we look at the role of immunotherapy in autoimmune disease, and people who know the work that has been done in SJIA can appreciate that therapy in itself might introduce lung complications, so we have to be cognizant of that. And then lastly, and probably most importantly, diminishing lung biopsies means diminishing expertise in the field to be able to diagnose these rare disorders. And with that diminished expertise, you're not going to get the information you need to drive future clinical care. So I think we have to be very aware moving forward, as exciting time as this is, not necessarily to biopsy when you don't really need to biopsy, but to think carefully about every biopsy that does get performed and to make sure that it gets a very thoughtful consideration as well as preserving the tissue for future potential therapeutic modalities. So I'd like to acknowledge a lot of people, my close collaborators, but particularly all the patients and their families that have sent me biopsies for review, and clinicians. And also, thank you very much in general.